My name is Hilda Mekelenkamp, and I'm a pediatric stem cell transplant nurse in Leiden in the Netherlands, and also a postdoctoral researcher at the Department of Ethics and Health Law. And besides that, I'm serving as the EBMT Nurses Group President. And thank you for inviting me today. And I'm very happy to cover the topic of management of hemorrhagic cystitis. And I will share my screen with you so you can follow my slides. Hopefully that's going well. I hope I can see you as well. Yeah, I can. Yeah, I also have some slides from your side to show that this classroom session is brought to you by the Blood South Africa. And this is the management team. And here are some housekeeping notes. And I really can encourage you to bring interaction. Feel free to add any question or comments to the chat box during the meeting. And of course, I'm happy to respond to that. And please also feel free to interact. There are CPD points. And of course, there's a great WhatsApp group, I have to say. I think this is really great how you communicate with each other. And feedback is also welcomed. So today we are talking about the management of hemorrhagic cystitis. My first question is, have you seen hemorrhagic cystitis in your clinical practice? And probably you can show this by putting a reaction with a thumbs up if you have seen this. I don't know if you can know where the react button is, but it's in the bottom of the screen, and then you have there the thumbs up. I see a couple of them. And I was also wondering if you see it a lot. Do you see this often? Probably you can also give a thumbs up if you see this often, because I think this has changed in the last years. Yeah, there are some persons saying that they have seen it a lot. So what is actually, so some didn't do it. So we will cover it today, and hopefully at the end of today, you know a little bit more about what is hemorrhagic cystitis and what we can do as nurses to cure for these patients, and also what the treatment involves. And what is hemorrhagic cystitis? That is a condition in which the lining of the bladder becomes inflamed, cystitis, and starts to bleed, pointing to the hemorrhagic in the word. And this inflammation leads to hematuria with or without symptoms, dysuria, but also pain and burning feeling while urinating. And it often also causes lower abdominal or suprapubic pain for the patients. And you can divide hemorrhagic cystitis in hematopoietic stem cell transplant in two different ways, like the early onset, and that is often seen within the first 2 weeks after the start of the conditioning, and typically during or within the 48 hours after the end of the conditioning. And that is often chemo-related, mainly due to the cyclophosphamide, and I'm not sure if in adult care, in adult HSCT, ifosfamide is a lot given. In pediatrics, we do not do that. So it's often cyclophosphamide related. It can also be radiation related, but then more the oncology radiation. And that is due to that the cyclophosphamide or ifosfamide is eliminated by the urine and also its metabolites. And while cyclophosphamide and ifosfamide is metabolized by the liver, it produces the metabolite acrolein, which is filtered by the kidneys and then concentrated in the bladder. And that will give inflammation and inflammatory cell death in the bladder urothelium, and also causes bladder inflammation and bleeding. And the maximum concentration of the cyclophosphamide is 2 to 4 hours after administration. And the time of duration that the acrolein is exposed to the bladder also contributes to the degree of the damage which it gives. And as said, this was the early onset. We also have the late onset of hemorrhagic cystitis in hematopoietic stem cell transplant. And I think when I started my work in HSCT, we only knew that hemorrhagic cystitis was caused by cyclophosphamide, but later on we learned that it is often also caused by other things. And late onset can be described as more than 2 weeks after HSCT, typically 2 to 4 weeks after transplant till 2 to 3 months post HSCT. And it often starts when the cells start to grow. And this kind of hemorrhagic cystitis is virus associated. It is often caused by the BK polyoma virus, and I often call it just BK virus. It can also be caused by adenovirus, CMV virus, or other polyoma viruses, but it is less often, these viruses less often cause hemorrhagic cystitis, I have to say. And the incidence of BK virus is 8 to 25% in pediatric patients and 7% to 54% in adult patients. And a lot of adult patients are already seropositive for BK virus. They have had that virus in the past. And now during the immunocompromised period, they got a reactivation of that virus. How in the BK viruria is seen in 50% of all HCT patients, but an overt hemorrhagic cystitis only in about 20% of the patients. Sorry, hemorrhagic cystitis is sometimes a difficult word for me. And what are the risk factors for hemorrhagic cystitis? Of course, the chemotherapy, which I already named, the cyclophosphamide or ifosfamide, radiotherapy can be a risk factor. The viral infections or reactivations of these, the BK virus, GC virus reactivation can also be an adenovirus, but also having a catheter can be a risk factor. The presence of pro-hemorrhagic abnormalities of coagulation can be a risk factor, and also severe thrombocytopenia. And of course, also mucosal inflammation has a big part in causing this complication. Also is seen that in haplotransplant compared to unrelated donors or matched related donors, often there's more often hemorrhagic cystitis. Also, the age of transplantation might be a risk factor, especially among pediatric patients. In patients older than 7 years, it is more often seen. And also the presence of graft versus host disease, especially grade 2 to 4, is a risk factor. Also, donor source can have an impact, like the cord blood and the peripheral blood cells more than the bone marrow, and the conditioning regimen components and intensity, of course. And then, for example, especially ATG, cyclophosphamide, and busulfan. What about the diagnostics? Of course, you start with the blood count with platelets, and we also have to consider the coagulation. But also viral cultures and or PCR for BK, GC, or adenovirus in the urine and the plasma, and urine sediments, ultrasound of bladder assessing clots sizes. And you can also think about consulting a urologist in case of severe hemorrhagic cystitis to assist with bladder irrigation and catheterization. But oftentimes diagnosis occasionally derives from exclusion of alternative causes. So if it's not an infection, it could be, for example, something else. Sorry, there is a kind of noise going. And before we can and for diagnosing, it's also important to grade the kind of hematuria, and hematuria can be graded as follows. And then grade 1 is microscopic, then you only can test it with in the laboratory, for example, or with a stick. Grade 2 is macroscopic, 3 macroscopic with clots, and grade 4 that requires a lot of other interventions. And to see if you have to diagnose the hemorrhagic cystitis, there are 3 criteria. First of all, the clinical symptoms and signs of cystitis, such as the dysuria and the lower abdominal pain. And then the second criteria is the hematuria, and then it should then be grade 2 or higher, like the macroscopic or further macroscopic with clots or needing other interventions. And in case of the late onset hemorrhagic cystitis, also the viruria, and then also the more than 7 log to 10 copies per milliliter. Then what could we do to treat it? First of all, it's important to optimize the coagulations, and often that can be done with platelet transfusions. I don't know what your clinical practice is, but we give also a lot of tranexamine acid when there are bleedings, but this is in these cases is contraindicated because then you can expect clots also in the kidneys, and that is really dangerous. And of course, you have to give blood transfusions in case of significant blood loss, and that can happen, of course, in the case of our HSCT patients when it starts around week 2 or 4. For the patients, it always also can help to relax the bladder and to give medications that works against the spasm of the bladder. And one of the most important treatment aspects is hyperhydration to prevent the clot forming. And also forced diuresis will help for that, because then the urine also will enter the body, left the body sooner, and that it will help to prevent the clot forming as well. And in case of clots or imminent obstruction, then catheterization and bladder irrigation can be considered. And if this is very severe, also uroscopy with clot evacuation and bladder irrigation can be considered. But you can imagine in those mucosa, which is already very severe attacked, yeah, this is also not a pleasant feeling for the patients and probably causing extra irritation. And in the BK virus, hemorrhagic cystitis, cidofovir will be given. The treatment can be done weekly or bi-weekly. That really depends on a local protocol. But you need to be aware that this is very nephrotoxic, and so also probenecide and a lot of hydration should be given together with the cidofovir. And one of the other most important things is pain management, because hemorrhagic cystitis causes a lot of pain in these patients. There are also things that can be considered, which is probably not very well researched, but there are some cases that hyperbaric oxygen might be of benefit in repairing and regenerating the urothelial mucosa, but not a lot of centers do have these facilities to offer this to their patients. So it's also a practical problem there. And what I already said, you can do also cytoscopic interventions, and then probably applicate fibrin glue or platelet-rich plasma to stop the bleeding. And there, in the future, there might be a potential role from MSCs and virus-specific T cells in case of the BK viruses. And which is something which is not really evidence-based, but can be tried, is an alum 0.5 to 1% or etching fluids while irrigating the bladder. That can be done. So in case of bladder irrigation, I think a lot of you have seen that in your clinics. If you have seen hemorrhagic cystitis, there the goal is not to treat the hemorrhagic cystitis, but just to prevent the clotting and not to prevent the bleeding, because catheterization is a risk for bleeding, which I already pointed out. And we should rinse based on the urine color, and the goal of is the urine with a light rosé color. When there is brown urine, then there is no need for increasing the irrigation, because there is no active bleeding, and brown urine is pointing to old bleeding. And always rinse with the fluid on room temperature. And I think we normally use saline to rinse it, but I must admit it was not necessary to use irrigation for a while in my clinical practice. I know this from years ago, but in the last years, we didn't see that severe hemorrhagic cystitis anymore. And rinse only manually in case of very bloody urine with clots, or in case of leakage, to prevent infection and bladder irritation. And of course, a very important part of our management, especially as nurses, is the psychosocial guidance and guidance in information, and of course, the family participation. And yeah, so if you've seen in the treatment, there is not really one aspect that should be done. Only probably in BK virus you can give cidofovir, but in the other things it's more supportive care what we gave. And so one of the most important things that we do not see that much hemorrhagic cystitis anymore, especially the early onset, is that we have prevention for the chemo-related. And nowadays, we always give hyperhydration, this forced diuresis in the while we're giving cyclophosphamide, for example, 3 liters per square meter every 24 hours. And patients should have a diuresis of more than 250 milliliters per hour. And this will be done, this hyperhydration and forced diuresis, during the days of chemotherapy until a day after. And we also gave the pharmacological prophylaxis in the form of MESNA, which is sodium 2-mercaptoetane sulfate. And that should be started right before the chemo administration and should be continued every 3 hours. And each dose is about 20% of the cyclophosphamide dose. So in total, each day, 120% of the cyclophosphamide dose will be given to those patients. But I know there are some different protocols on these, but it's important to give this because this MESNA impacts acrolein into a non-toxic compound. And so with that, we prevent the damage from the acrolein in the bladder, also in the kidneys.
May I interject, Hilda? Sorry.
Yes.
Sorry.
Yes.
May I ask other guests to mute themselves, please? There's some disturbing noise to background. Please mute yourselves. Thank you.
Thank you. What can be done in prevention for virus-associated hemorrhagic cystitis? Actually, not that much, because ciprofloxacin, which is a fluoroquinolone, I cannot pronounce that very well. Ciprofloxacin, you know, I think all that seems efficient in vitro, but in vivo, the efficiency is weak and it does not significantly affect the incidence of hemorrhagic cystitis. And when we give ciprofloxacin, we have the risk of antibiotic resistance. So therefore, it is not recommended to give ciprofloxacin as prophylaxis for virus-associated hemorrhagic cystitis. Then probably some patient's experience, because this is a really impactful complication of the hematopoietic stem cell transplantation. And I found a nice article of Italian colleagues, and they did a qualitative research, and they were able to interview 9 patients and did interview them and summarize these experiences into these 3 main topics. They identified, first of all, the topic of being informed, and most of the patients recognized that they were informed about these kind of complications, but still when it happens, it mostly surprised them. And then there's a phase that the complication has started, and as you can see, there were a lot of sub-themes described by the patients. For example, one of the sub-themes is, why did this happen right to me? Or living in the bathroom, counting the urine drops, experiencing pics of shooting pain due to the clots, bringing me down, I'm finished, trying to do something by myself, starting from the basics, floating between love and hate, the urine, that's addressing the urine catheter. And then a third phase where it has gone, like that they have to deal with the consequences, and also a relief that finally the end has arrived. And I here listed some quotes of them, of those patients, because I think that is very illustrative for how patients feel, and you might recognize this from your own clinics. And for the being informed phase, one patient said, this complication was foreseen after the transplant, but even knowing this, I told myself it is not possible. Or when the hemorrhagic cystitis has started, it was annoying. I knew it was related to the medication, as I was told. At the beginning, one does not know all these little things. And that's also, I think, something that I recognize from our patients, because patients always hear a lot of complications when they start a hematopoietic stem cell transplant. But yeah, experiencing such a complication is a different aspect, because you cannot expect to experience all those complications, and I think this is one of those that they're not thinking about. And it also affected sleep. Like this patient said, I had analyzed myself. I went once every hour to the bathroom. At night, I couldn't sleep. I woke up and I had to go to the bathroom. Or it was an excruciating pain in the bladder. I was starting and I felt something moving and coming out. It was just a lump, because then it went out and everything was reestablished. I think that is also one thing I really recognize from my own practice. Also, the little children pushing out those clots was really hard for them. Sometimes it looked like
Lisa,
deliveries.
I think that you have a knob that you can.
I did not
I
have
see
that.
you muting me, but you are muting. You can mute everybody except for Hilda.
Can I do that?
I
Yeah,
think
I've
it
been
is
doing that as
Lisa
well.
who has to do it.
Yeah, I managed to unmute a few, but they keep unmuting themselves.
You've got a knob that says mute all, I think.
Okay, it's done.
Oh, I had to unmute myself. Sorry. Also, then that cure was not guaranteed was really a worry for patients. So that was expressed by this quotation. And this one was also nice, I think, for us to know. A patient said, outstanding nurses, they supported me. It's important because you do not understand at that moment. And also cleaning the urinary tract was important for patients, not only by hydration, but also by washing. And that's an important message for us as nurses, I think. And also one patient said the catheter was not a solution. The only effect was that it gave me the pressure on the bladder. And after that, I couldn't hold it back. I was always wearing diapers. I was terrified of staying like this. So it gives a lot of worries, actually. And when it has gone, patient said, luckily, bad memories are forgotten. The worst is over. But also, it erases so much, so they avoid remembering those experiences. So then a bit is summary. These are the key points. We have the early onset hemorrhagic cystitis and late onset hemorrhagic cystitis, where the incidence of early onset is very low, like lower than 3%, late onset 7 to 25%. And what he said is, I think that's also reflecting in clinical practice. Early onset hemorrhagic cystitis is nowadays rare. But the genesis is that the early onset is caused by chemical drugs, bladder or the damage of the bladder mucosa, and the late onset by the BK virus infections, or probably other infections, probably could be caused by donor alloreactivity. Diagnosis can be done by microhematuria with dysuria, increased urinary frequency, low abdominal pain. And in the late onset, also macrohematuria with dysuria, increased urinary frequency, low abdominal pain, of course, a high load of BK viruria and viremia. And of course, you can see a bladder inflammation at the ultrasound examination when that is performed. How hemorrhagic cystitis can be prevented with hyperhidration and MESNA if chemo is given with cyclophosphamide and forced diuresis. Prevention for late onset hemorrhagic cystitis, hyperhidration and forced diuresis. I think that's more to prevent worse. And what I already explained, ciprofloxacin is not recommended. The therapy is in early onset and also late onset hyperhidration, forced diuresis. Hyperbaric oxygen therapy can be considered. In late onset, also cidofovir can be given. And the application of fibrin glue or by cytoscopy can be considered. but there is a lot limited evidence and experience for all these therapies, like the hyperbaric oxygen therapy, the fibrin glue, platelet-rich plasma, and other treatments. And experimental for the future could be for the late onset virus-specific T cells and mesenchymal stem cells. So the take to work message, especially for us as nurses, I can say that in HSCT, early onset cyclophosphamide haemorrhagic cystitis is cyclophosphamide related, and late onset often BK virus related. It recovers generally after 3 to 5 weeks, but in that qualitative study, which I already mentioned, patients said they experienced these complaints far much longer. And sometimes it was noted in their charts that it was only a few days. They experienced it quite longer because I think the complications for them feels more intense and also have longer effects. It needs for sure a prolonged hospital stay and nursing care for these patients, and including higher cost, of course. The role in increasing of mortality is controversial. There are some arguments that could be said that it is increasing mortality, but also not. And I think in a very, very severe hemorrhagic cystitis, in these patients, we always also see other severe complications. So then there's always the question, what is what? For sure, hemorrhagic cystitis is a very impactful experience for patients, and therefore offering emotional support for us as nurses is really important. That was nicely illustrated by one of the quotations from the qualitative research. And more specifically, we as nurses can support patients in being hopeful and that these complications will resolve. However, we do not have a specific, very to the point treatment, but all the other supportive aspects. But giving them hope is really important, but also giving information about the cause and the process. It was one thing that struck me from that qualitative study. All patients said they were informed about it before they go to transplant, but while experience these hemorrhagic cystitis, they do not know that it was caused, for example, by the BK virus, and it was for most patients the cause of the hemorrhagic cystitis. So I think that's also a huge role for us as nurses to give that information about the cause and the process and what it can look like. For sure, also supporting hydration and washing. I also read in that qualitative paper that patients really feel relieved when they were offered a lot of washing, and they are all asking for bidets. I know not all countries do have bidets, but probably you can offer them something in the shower or whatever. But also supporting sleep and comfort, because we also saw in that qualitative quotations that they could not sleep, and we can also help them in supporting sleep and comfort. And that should for sure include also analgesics, because it's really painful. This is an overview of the references, so you can have another look at the literature. And I was actually wondering if there are any questions, or probably you have a valuable lesson that you have learned in your clinical practice that others might benefit from related to hemorrhagic cystitis. So I would say I open the floor for questions or lessons learned. Thank you for listening.
Thank you very much, Hilda. That was very, 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 very insightful and informative, or whatever word you want to use. And thank you very much. I like your slide on information to take home, like yeah, especially when you're talking to the patient. Information that we give to the patient is very, very important, because everything to them is a surprise, comes as a surprise, even though they would have been informed about what could happen, what could go wrong. But when it actually happens, and they don't remember all that. So it's important that we as nurses are well informed about such things, and we have information, and we are able to support them. Emotional support is very, very important to both the patient and the loved ones as well. Thank you so much, Hilda. I really enjoyed your presentation. Any questions from anybody, please? Any comments?
I'll stop sharing, probably then you can see my face, that's more. Yeah, any comments? Or probably you, I'm wondering, when I started my, as I already said, working in HCCT, I think we saw a far more severe hemorrhagic cystitis than we nowadays see. And I really remember severe cases where we really need to support the patients, pushing out all those clots. I really remember them. But nowadays it's a little bit less, I think, and less severe. What is your experience?
Yeah, I strongly agree. And again, the use of cyclophosphamide nowadays post-transplant, it has actually made a huge difference from when we started, maybe over a decade ago. But the introduction of cyclophosphamide, it prevented and or minimized the risk of hemorrhagic cystitis that I've noticed. Yeah, and again, like I said, health education is important to patients, because I was looking at some patients' experiences, patients not reporting because they thought it's just a cleansing somehow or whatever. So it's important that we educate our patients and the importance of reporting anything. But then again, the urinalysis from our side, that we never miss that. We do our own dipstick to make sure, especially for patients that are at risk. It is important. One of the things that nurses should never miss at all. Yeah, it'd be nice to hear other comments from other people. I could see some people just saying, thank you, it was informative. Thank you, and thank you very much. Hilda, well done.
Thank you so much.
And I hope we will be able to get these presentations on our this is recorded, so some people can have a look, for especially those who joined late. And those who missed the session today. I know quite a lot of people couldn't make it today because of the busyness in their centers. Some are having interviews, others and a lot of sort of things. But I really enjoyed your presentation, and well done.
Thank you so much. Thank you so much. I think there's one question from Charlene.
Hi, Hilda. I'm Charlene. I'm a clinical hematologist in Durban. Thank you so much for your talk. So my experience is the hemorrhagic cystitis, not so much from chemotherapy. We do not have a lot of this happening, but it's due to the BK virus. And
Yeah.
what I found, it occurred in the adolescent patients more than the adults. Yeah, so it's just for the nurses to be vigilant, in the post transplant period. I think that's just my little experience, but it can be quite severe when it's due to BK virus. So yeah, but thank you so much.
Thank you so much. Yeah, that's true. It can be also be very severe from BK virus. That's really true. Thank you.
I take it there are no any further comments or questions. Thank you very much, everyone, for attending today's class. Our next class is on the 1st of October, and the subject is neutropenic fever, one of the biggest subjects as well. And it will be interesting to know what our speaker has to tell us. Thank you so much, Hilda, and have a lovely evening or afternoon where you are. And for the South Africans, it's evening. And I hope they all have a wonderful evening. Thank you so much, ladies, for attending, and see you soon.
Thank you for having us, and have a lovely evening.
Thank you. Bye.
Thank you. Bye.